Alright. Hello, everyone, both in person and virtual, and welcome to Caring and Living as Neighbors Parallel Event, brought to you by CLAN, Mates for Kids, and Lehigh University. My name is Nikki Pasterchik, Youth Representative to the United Nations for CLAN, and I will be presenting this event along Sophia Russo, who is also a United Nations Youth Representative for CLAN, Santa Gates, who is a Youth Advisor for Community Outreach, and Grace Stark, who is a Youth Advisor for Governance Support and Assistant Treasurer for CLAN. Please ensure you are muted if dialing in virtually. Lastly, this event will also be recorded and posted with a report on CLAN's website. We would like to acknowledge the lands that everyone is dialing in from virtually. We invite you to post the traditional lands that you are on in the Menti now. For everyone in person, we acknowledge that we are presenting from the lands of the Lenape people, and we pay respect to elders past, present, and emerging. As CLAN is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing education to lands, water, and community. We pay respect to First Nations peoples internationally and to their cultures and elders past, present, and future. This event is in partnership with the Lehigh University United Nations Youth Representative Program. The Lehigh Youth Representative Program started in 2008, where high-achieving Lehigh students are matched with UN-accredited NGOs. There's currently a cohort of about 22 youth representatives that serve as the voices of the NGOs at the UN. CLAN is one of 9 NGOs and one of Lehigh's strongest partners. CLAN currently has 2 UN representatives, Sophia and I, who advocate for CLAN at United Nations events such as this one. This program allows youth to have a voice in global matters, and in our case, treatment for children with non-communicable diseases. This year's CSW theme is Innovation and Technological Change, and education in the digital age for achieving gender equality and the empowerment of all women and girls. Our event's focus on newborn screening aligns with this theme, as it is a technology that contributes to gender equality by providing equal diagnosis of chronic conditions to fight the effects of economic and gender biases on treatment. In addition, CLAN's work with newborn screening follows the Sustainable Development Goals of good health and well-being, gender equality, reduced inequalities, and partnerships for the goals. For those unfamiliar with the specifics of newborn screening, it is a heel prick method where blood samples are taken from a newborn and tested for multiple genetic, metabolic, endocrine, and other long-term conditions. This is pivotal for children with chronic conditions, as early diagnosis and treatment within a few days of birth can prevent morbidity and mortality. For more information, here is a quick video from a mother with a daughter who benefited from newborn screening, and this is on behalf of the CARES Foundation.
Hello, my name is Christy, and I have a daughter with salt wasting, CAH. When we had her, we knew that there was something going on. My aunt is a surgeon, an OB-GYN surgeon, and she was second in the room, and she whisked her away. And then a whole team of doctors came in white coats and told me they were taking my daughter. They told me that she had ambiguous genitalia, and I did not know what that meant. And then they did the newborn screening and found that she did indeed have CAH and a significant rating on the Prater scale. So there is another death in the family of an infant, and it makes me wonder if maybe he had had a newborn screening, then maybe he would not have died. So to me, it's extremely valuable, because for some parents, their child doesn't show signs externally, and if they don't know, then they can't save that child's life. So for me, I think it's critical, and I'm grateful for it. Thank you.
Okay, so starting off with history of CLAN. CLAN is an Australian non-governmental organization founded in 2004 by Dr. King. Stakeholders are involved in this framework to ensure lasting development, including industry, families, health professionals, philanthropy, and policymakers. These groups work together to facilitate tangible change. Plan's strategic framework for action operates through 5 pillars. Pillar 1 is affordable access to medication and medical equipment, while Pillar 2 is education of the individuals, families, communities, health professionals, policymakers, and the international community. This is done through research and advocacy, while Pillar 3 is the optimization of medical management, including primary, secondary, and tertiary prevention with a biopsychosocial focus. Pillar 4 is the encouragement of family support networks, while Pillar 5 is working towards reducing financial burdens on families that result in poverty, helping people to become financially independent so that they can provide the necessary health care for their children long term. There is also the newborn screening link. PLAN is focused on promoting equitable access to newborn screening services for all children of the world. Special efforts are going to be needed to reach babies from resource-poor settings and families. The incredible work happening in Indonesia can help show what is possible when governments lead the way and everyone works together. I'd now like to introduce Dr. Kate Armstrong, founder of PLAN and co-chair of Mates for Kids.
Thank you very much, Sophia. I hope that you can hear me okay. Thanks very much to the team. Thanks very much for the team on the lands of the Lenape people in New York. We're really proud of the work that you're doing. I'm really grateful to colleagues joining me here in Buenos Aires as well. Pediatric endocrinologists from around the world have come together for the International Meeting on Pediatric Endocrinology this week. And we've had some really great discussions around helping children with chronic health conditions enjoy the best quality of life possible. If I could have my next slide, please. So I'm just going to give a bit of a brief introduction to Mates for Kids and why it's just so important that we all work together to scale newborn screening to achieve the SDGs, but also contribute to gender equity. Next slide, please. So Mates for Kids is a coalition of like-minded individuals and organisations coming together to really identify and implement some practical solutions to achieving affordable access to medicines for children around the world who are living with congenital adrenal hyperplasia. There's a briefing paper that we prepared for the WHO, which the team will be providing a link to in the chat, where you can learn more about Mates for Kids. But we really have set a very bold goal to reduce the mortality, the preventable mortality associated with CAH by 30% by 2020. And we've come together here in Buenos Aires for the first time face-to-face and people joining remotely to discuss how we might achieve that goal. And really, we understand that access to essential medicines will be critical for that, but we also acknowledge newborn screening will be really important as well in reducing mortality. Next slide, please. This is a really confronting slide, but the reality is that when a child dies from a preventable health condition, they've lost their voice. They can no longer advocate for newborn screening. They can no longer say how important it is for the world to scale newborn screening. Likewise, parents, when they lose a child, they usually are so depressed, they go away and their voices are lost as well. So we're really not going to have the voices of the people who are most affected by the failure to scale newborn screening being heard on this topic. So we need champions. And I'd like to acknowledge Professor Aman Palangan from Indonesia, who has been advocating on this since our first UN event in 2010, and others such as Maria Craig and our teams here from GPED and other organisations around the world who are really passionate about speaking up and advocating for children and the importance of newborn screening and access to medicines. Next slide, please. The reality is that newborn screening is really effective at reducing mortality and morbidity. This is a picture of a little baby who was born healthy, and then 3 weeks later was failing to thrive, vomiting, drowsy, and would have died if it hadn't have been for the fact that doctors fortunately diagnosed them because we were living in Australia, and the child was able to access good health care and access to medicines and go on and have a good life with CAH. But the reality is most children in resource poor countries who get to this stage die. Sometimes if they stay alive, they experience severe disability and preventable morbidity. And so the difference between children living with CAH in high-income countries and low-income countries can be really profound. Not only that, we know that girl babies are less likely to be presented to health professionals for care. Families in some countries are less likely to invest money to care for girl babies and girl children with chronic and complex health conditions. And likewise, we know that mothers too often bear the brunt of caring for children with chronic health conditions. So anything that newborn screening can do to reduce preventable mortality and morbidity will really contribute to gender equity. Thank you. Next slide. The question then really is, how are we going to do this? We have been working for a long time. CLAN has been working since 2004 in this space, and Mates for Kids started in 2021. But we all agree that we want to see newborn screening scaled, but how are we really going to do this? And the reality is we're very fortunate. The UN and member states have identified 2030 as a key date that we can potentially work towards if we set our sights on contributing to the SDGs. Next slide, please. There are 3 main SDGs that relate to this topic and to newborn screening. That's SDG 3.2.1 and 3.2.2, reducing neonatal mortality and reducing under 5 mortality. But SDG 3.4 spells it out really clearly for us. SDG 3.4 calls for a reduction by 30% in mortality, preventable mortality.
She's amazing, isn't she?
By 2030. I think you might just need to go on mute. Thanks. Thanks for the kind words. But so we really need to all work together if we're going to contribute to these SDGs. So how can we do it? How can we reduce mortality? Improving access to essential medicines, scaling newborn screening, and strengthening communities using CLAN's framework there. And we thank everybody who has joined the journey so far. And we're extremely thrilled now to hand over and listen to more. I'll hand back to the team so we can really listen to what Indonesia is doing in this space. Thank you, team.
Thank you so much, Kate. We will now discuss the amazing work being done in Indonesia and more broadly with newborn screening with our following speakers. I would now like to welcome the Minister of Health of Indonesia to present his video message, and we invite Ms. Lovely Daisy to speak now.
Speakers, ladies and gentlemen, good evening. It is my great pleasure to have the opportunity to say a few words at the United Nations 67th sessions of the Commissions on the Status of Women, which focus on the importance of newborn screening for achieving the Sustainable Development Goal target and gender inequality. Distinguished participants, it is estimated that 8 million or 6% of newborns worldwide are suffering from congenital disorder. And globally, it contributes to the top 5 cause of global burden of disease. In Indonesia, congenital disorder is the #1 cause of burden disease in baby and toddler. As many as 48,000 newborns are at risk in developing congenital heart disease every year. For every 12,000 babies screened, 1 newborn suffers from congenital hypothyroid. Many babies born with health conditions. We have no family history and shows no symptoms at birth. Therefore, newborn screening provides opportunities in early detections of certain medical conditions which can affect child's long-term health and survival. Early detections will make it easier for the right intervention to to be delivered in time to prevent death and disability. Innovations such as heel-prick blood tests for newborn babies combined with hearing and pulse oximetry screening tests have the potential to diagnose several conditions and to prevent developmental delay, disability, and death. Ladies and gentlemen, the Ministry of Health of Indonesia is currently undergoing health system transformation. This momentum should be used to encourage empowerment and to increase participation in providing excellent health services and accessibility for all life cycles, including strengthening the coverage of newborn screening program. As part of the primary and secondary healthcare transformations, we will ensure that each newborn will have access to heel-prick blood tests and pulse oximetry screening tests to detect congenital hypothyroid and congenital heart disease. Finally, I truly hope this session could provide us the opportunity to reflect and move forward to better innovation support by technology, to achieve gender equality and empowerment for all women and girls. It is time for all of us to work together to build a better future for women and children. Thank you.
And we would now like to introduce Dr. Aman Pulugan, who is a professor of pediatrics and a pediatric consultant among many of his roles. Aman, please feel free to now share your slides over Zoom and to introduce yourself.
Thank you, Kate. I'd like to share my slide. Can you hear me?
Yes, we can hear you.
Okay. Let me share my slide. Okay. I'd like to share about the opportunity about the CAH screening in newborn in Indonesia. Like our Minister of Health said that we just relaunched our newborn screening for CH. Yeah. So and probably we hope that next year we can include this CAH screening also in Indonesia. So like I was mentioning before, this is the this is the Indonesia. We have 270,000 million population for 17,000 islands and almost 5 million newborn every single year. And with only about 53 pediatric endocrinologists, so it's quite a challenge right now. So what's the incidence or prevalence of CAH in Indonesia? Nobody really knows because not reporting, and we only have a really small registry, so no data available yet right now. But we have the registry. This is just like the tip of the iceberg. If you can see it, you know, if the doctor, you know, they are good in register their patient, mostly from Jakarta, but no data we have it, but we have the data from our community that they order the medicine, and sometimes we get the report from the hospital. So still a lot of, you know, non-registered. So this is the distribution of the sex also and age of diagnosis. And most of them, we don't really know when they start the diagnosis because it's quite difficult to know. But right now, since we don't have any newborn screening, some of them we know about the age of diagnosis between sometimes 10 to 14, and some of them, you know, 5 to 9, and only really little from 0 to 4 years old. And also, we don't know which one is the simple virilizing or the classical losing mostly, because no data about 61%. So newborn screening in Asia Pacific, we know it, you know, in a country, if they have a good newborn screening, the infant mortality rate will be going down. So we can prevent the, like Kate was mentioning, about SDG number 3. This is access to medicine, but also to decrease infant mortality in all countries, including Indonesia. So infant mortality is the predictor coverage if we have a good newborn screening. So what happened in Indonesia, only for CH right now, we have previously before the pandemic, we got it, less than 2%. But right now, the Minister of Health want to increase it about 50%. This is a huge increasing by next year, or this year, at least the end of this year. Worldwide condition of CIH screening, as everyone knows the data, Belgium 125,000 and Netherlands 111,000. That's really range all over the world. And in Asia Pacific, the highest probably Philippines, 1 in 6,000, and the others still, not reported really good. So what's the cost effectiveness? France, $2.6, Canada, 3.1. Maybe GP know about this. Then Canada, Netherlands, we know it. USA, we know it about the cost effective. Cost per life year vary between 30.9K to almost 2 million US dollar per. So it's really variation. So what's happening in Indonesia, newborn screening? Why do we need to screen? If we assume that our incidence is the same as Philippines, then we will have at least 19,000 at least, and the 14,000 they start losing. And how much it costs if the patient came to adrenal crisis and must be hospitalized for several days of sick, increased mortality, long-term effect of neurodevelopment. So this is what we will face. This is what, I was explaining to our Minister of Health, that we have to start at the same time also with the CH. So the quantitative issue of CH screening in Indonesia. So before we talking about, patient right also, but the national health insurance for all Indonesian citizens, this is still, but the government right now wants to cover it. Our data, this is just from 6 hospitals, in 4 provinces. We did the health pricks for 1,200 patients for CH and for CAH. This is really surprising. We got 10 out of 1,100 patients positive from CAH. And when we recall, only 3 came, 2 were positive. So our data, 2 out of 1,100. So we don't know really in Indonesia situation, but our data was saying that we have 1 in 550 or 560 something baby with CAH. This is, that's I feel that we have to start as soon as possible. So the sample number, of course, didn't reach the calculated. Increasing awareness in the society and maintaining good partnership with health services are of importance. So newborn screening, the way forward. What should we do? Of course, increase public awareness about CAH, healthcare provider, all the citizens, build the national system. This is what the Minister of Health is doing. Government will. And government will, you already heard about what our Minister of Health said from Indonesia, that we will do it. And of course, according to Padilla, Carmen Chita, huge population in some country like Indonesia, high rate of home delivery in Indonesia, in India, a lot of country. So lack of lab, okay, we will overcome it. Early discharge, of course, we have to overcome this. So the conclusion is, we want to avoid fatal adrenal crisis. Of course, we have to really count about cost effective. Early gender assignment, I think we know about CAH is gender assignment is really important in Indonesia. Decrease mortality and morbidity. Early therapy, better outcome. So we have to do the CAH screening. So healthcare provider, instructor, support, patient awareness, political will. So newborn screening of CAH in Indonesia, we have to start. I just want to quote from the book that I used to read. Someone said, it doesn't matter when we start. It doesn't matter when we start. All the better, we have to start. Thank you.
Okay.
Thank you, Aman, for your insightful discussion of newborn screening and the work in Indonesia. I would like to now introduce Fatima Idayan, Community Development Officer for CLAN in Indonesia, to speak about why newborn screening is so important for gender equality.
Hi everyone.
Okay.
So my name is Fatima. I had the opportunity to spend 6 months in Indonesia working on newborn screening initiatives. And I'll just be going through some of the things that I learned in my time over there. Specifically, why is newborn screening so important for girls? Next slide, please. So newborn screening, what is it? I'll briefly touch on this. It's, I know the others explained it so well. So newborn screening is a vital public health measure, and it just consists basically of a heel prick test done on the baby's first few days of life. That blood sample is then taken to a lab and is tested for any possible congenital disorders. This gives us the opportunity to be able to detect disorders early in life and then also prevent any impacts that that disorder may have if not treated early. Next slide, please. So what is congenital adrenal hyperplasia exactly? So essentially it's a congenital disorder of the adrenal glands and results in life-threatening adrenal crisis without treatment. Children tend to present with vomiting and failure to thrive at around 3 weeks of age. However, this can be diagnosed with newborn screening. It is a lifelong condition treated with affordable tablets several times a day and tends to affect both boys and girls differently. So once it's treated early, it can be managed and children tend to grow up and have the same outcomes as children who haven't been diagnosed with CAH. But the problem, as we'll see in a couple of slides, is that not a lot of people, specifically in Indonesia, have access to newborn screening. Next slide, please. So what exactly does this mean? So the adrenal glands in CAH can't produce enough cortisol or aldosterone, but they do produce excess androgen. And this excess androgen results in a lot of physical changes, specifically for girls, and is the leading cause of a range of psychological impacts associated with the disorder. So without treatments, girls are at a higher risk of negative psychological impacts due to those excess androgens. However, effective control of CAH will be able to prevent any negative side effects, allowing for a positive quality of life. And this really stresses the need for educational awareness to be able to give patients the tools they need to effectively manage CAH, as well as parents giving education to parents around what a child with CAH, what symptoms they may present with, and how they can best support that child. Next slide, please. So this slide comes from the interviews that I had taken with families while I was in Indonesia. And the points that I've just listed were some of the key themes that kept popping up and were consistent throughout 40 interviews. The first one is affordable access to medication. This one was an extremely important one. A lot of families indicated that they weren't able to afford the medication. And this led to instances where they had to either ration the medication or just completely skip taking it for periods of time, which obviously led to a range of detrimental impacts on the child's health and well-being, as well as transportation costs. So families indicated that most of the times the cost of travelling to the city and obtaining medication cost more than the actual medication itself. Education and advocacy. There was a lot of concern over the fact that parents struggled to find publicly available information about CAH that was free of medical jargon and that was easily understandable. MBS provides opportunities for early intervention. And so I had the opportunity to speak with families who both had the chance to diagnose the disorder for their baby early in life, and families who've had children with a late diagnosis. And for children who've had an early intervention, when I spoke to families, I found that they had much better outcomes and they were able to control for any psychological impacts associated with the disorder, such as the maturity and physical developments for most children. And they were able to have discussions with their children about CAH and what it means, as well as their responsibilities, whilst children with a late diagnosis tended to face a range of other issues, specifically with gender identity. And this touches on the next point. So specifically with girls, they face challenges with gender identity, puberty, stress, and friendships. And the gender identity part just comes from late diagnosis mostly. So a lot of the times girls were assigned the gender of a male at birth. However, a couple years after, when they were diagnosed with CAH, found out that they were actually a girl. And there was a lot of discussion around what they had to do essentially, and whether they should continue raising the child as a boy or change into a girl. And that obviously led to a lot of issues with gender identity, formation of friendships, as well as concerns over intimacy, partner acceptance. When I asked parents about what their major concerns were in terms of the future for their child, a lot of them highlighted that relationships aspect, whether their children were able to form and maintain relationships, as well as reproductive concerns and stigmatization from the culture as well. So with cultural norms specifically, so like Kate mentioned before, mothers tend to bear the brunt of disorders such as CAH, and a lot of mothers have mentioned that people from the community tended to blame the mother for the child's disorder, saying she was either unworthy of having the child or this was a punishment of some sort. And so with girls, again, largely on the gender identity part, sort of because girls who were raised as boys due to late diagnosis tended to have more boyish preferences. They tended to want to play with boys more, preferred outdoor activities and so on. That caused a lot of cultural stigmatization. And so again, that touches on the last point, that fear of scrutinization as well. Next slide, please. So where do we go from here? So leveraging technology has never been so important. Technology essentially through MBS gives us the opportunity to be able to diagnose disorders early in life and prevent all those negative psychological as well as physical impacts associated with those disorders. It makes it easily diagnosable. However, we do need to work towards increasing accessibility of newborn screening to resource-poor countries. On the diagram on the left here is just CLAN's approach to a rights-based community development approach to enhancing access for diagnosis and medication. Next slide. So just to close off, newborn screening offers the opportunity to prevent serious side effects of congenital disorders through technology, and we do need to work towards equitable access given how important it is and how it will change the outcomes of so many families and children in particular. And it's important to note that Indonesia is making amazing progress, and it continues to work towards enhancing coverage whilst navigating severe geographical challenges. And I'm very grateful for the chance that I had to work with everyone over there. Thank you.
Okay, Nikki.
Thank you so much, Fatima. I would now like to transition to Emma Santini, who will discuss economic analyses of newborn screening for CAH.
Thank you, Nikki, and hello, everyone. Good morning from Jakarta. I am an intern at the International Pediatric Association right now, and I am also the Caring and Living as Neighbors project officer for Meets for Kids, as well as a former youth representative for CLAN. So it's an honor to be here, and I thank you all for coming. Next slide, please. So today I will be talking about something Professor Aman briefly touched on, and that is the cost effectiveness of newborn screening. And really what it means to economically evaluate newborn screening for CAH. So this means exploring some financial underpinnings of implementation and scaling. Next slide. So for the sake of time, I won't go into too much detail because I think my colleagues have already done a wonderful job of explaining why we need newborn screening for CAH. But as we know, CAH has low prevalence and high mortality, which means that there are issues with diagnosis. And if we work towards newborn screening, we'll see that it's going to be a step towards health equity. In the Asia Pacific right now, we know newborn screening coverage reached about 95% in high-income countries, but remains below 5% in low and middle-income countries. And in Indonesia, it is less than 2%. So this ultimately will contribute to Sustainable Development Goals 3.2 and 3.4, among others. That's ending preventable deaths of newborns and children under the age of 5, as well as reducing by 1/3 premature mortality from non-communicable diseases. As we are at the Commission on the Status of Women event, it's important to note that in low and middle income countries, girls are less likely to survive CAH. So we really are taking steps to protect girls and privilege the lives of girls through championing newborn screening. And additionally, as Fatima noted, we spare families long-term economic and psychological hardship. So now when we talk about economic analyses, this is a little note on semantics. Typically in the healthcare field, we see two types of economic analyses. The first being a cost-benefit analysis, which is pretty much what it sounds like. Do the economic benefits outweigh the economic costs of a given policy? So this is considered typically the most comprehensive analysis you can do for assessing financial sense over the long run. However, in the healthcare field, we will commonly see what is called a cost-effectiveness analysis instead. And this is essentially asking how much does it cost to get a certain output from a policy. And this is really focused on the given outcome, and it is always comparative. So it is always comparing the spending required by two different interventions. And so ultimately, a cost-benefit analysis is always ideal. However, cost-effectiveness analyses are often chosen if it's too difficult to assign monetary value to benefits. For example, for cost-effectiveness analysis, really what you are looking at is just the cost. But ultimately, cost-benefit analysis is really great because you really will see exactly what the economic payoffs are. So to continue, I will go into the next slide and discuss this a bit further. So why are economic analyses important when dealing with newborn screening for CAH? First, we need to note that in many low and middle income countries, the rationale really stands behind the limited financial resources that are a primary barrier to budgetary and financial restrictions. So we see a lack of funding, which leads to a lack of necessary equipment and infrastructure needed to implement newborn screening. And ultimately, we see that this serves as a continuous reason to not pursue newborn screening, especially for disorders like CAH. And also, to continue, newborns identified by newborn screening to have a congenital disease may have inadequate treatment. So when we're taking a community development approach like Fatima had described earlier, it's important that we care for children and provide them medical services beyond mere diagnosis. So that means ensuring that they have access to medicine and access to financial and emotional supports. And that also is a cost we must take into mind. And in addition to that, we need to remember that newborn screening is costly to maintain over time. And ultimately, the mission to implement newborn screening is in competition with other public health issues, especially in low and middle income countries. Infectious diseases are still a priority, so we need to look at what the value of newborn screening is and how it fits into the greater public health picture. So ultimately, all of this is to say that while we know that newborn screening for CAH is so important and vital for the lives of children everywhere, it's also important to understand this economic impact so policymakers and decision makers can avoid overloading the public health system. Continue. And so right now, there is actually quite a lack of literature on economic analyses for newborn screening, and particularly newborn screening for congenital adrenal hyperplasia. But the literature that does exist is very promising, and I've included just two examples here to discuss very briefly. For the sake of time, I won't go into too much detail, but we see this first study on the top, and that is from Brazil in 2021. And so they conducted a cost-effectiveness analysis for CAH newborn screening, and they found that it appears cost-effective. So ultimately, they found that the incremental cost effectiveness ratio was around $25,000, and the WHO considers a strategy cost effective if it is less than 3 times the gross domestic product per capita of a country, which for Brazil at that time would have been $29,000 roughly. So it did appear cost effective, and in the most ideal scenario, it was extremely cost effective. And they confirmed also through this study that CAH newborn screening was indeed important in preventing mortality, morbidity, and could reduce the costs associated with adverse outcomes. So really important to note that this was a study that used a lot of estimations and also was centered in one geographical area. Also, it is a very recent study, so another maybe aspect of that to note. However, it really provided a great methodology for confirming that, yes, newborn screening for CAH did appear cost effective in Brazil. And so to move on, there's another study down here that is from Sri Lanka. And so this was a cost effectiveness analysis of congenital hypothyroidism, so not CAH, but congenital adrenal hypothyroidism is generally considered in a lot of the same realms as CAH. So we see that they had proven effectiveness. So their benefit cost ratio was 3.6, and anything above 1 is generally considered to make financial sense. So 3.6 is a really wonderful benefit cost ratio. And they found that newborn screening was not only effective in timely detection of at-risk babies, but also effective in providing a positive economic impact to society. And that is something I just want to talk about very briefly, is that when we have newborn screening for CAH, we avoid reliance on clinical recognition, and that in the long run will help the public health system become more productive and more efficient. Less resources are used on continually trying to diagnose children, and we see that greater society can benefit from initiatives like this. So moving on to the next slide. And of course, I want to highlight too that, as with any sort of initiative, we have hesitation. So we have a cost-benefit analysis of newborn screening in the Philippines. And this was not anything too concerning, but they found that screening for CAH individually is not cost beneficial. And what they did find that when screening for 5 disorders together, so that was CAH, congenital adrenal hypothyroidism, and then also galactosemia, phenylketonuria, and glucose 6-phosphate dehydrogenase deficiency, there was a net benefit. So what we might want to look at in the future is just a view of newborn screening holistically and where CAH fits into that on a greater newborn screening panel, and ensuring that if we're screening for CAH, we also are taking a look at other disorders. So I will just touch on some conclusions. Those studies really demonstrated that it is promising that CAH newborn screening is cost effective. There are a lot of challenges, and it's very complex to conduct economic evaluations, especially in the healthcare field. People who endeavor to conduct economic evaluations have to deal with some very tough questions, such as how do we place value on the life of a human being? But I want to quickly note that really one key point is that when we look at economic evaluations and their value in making decisions, such as whether or not to pursue a newborn screening program, they are beneficial, and it helps to understand economic impacts. Yet at the same time, we need to prioritize the humane aspects of newborn screening. So we need to consider that newborn screening, we know, saves lives and is so important for families with CAH and families with children who have other congenital disorders. And that is reason enough to pursue newborn screening. While economic evaluations like a cost-benefit analysis will provide so much other information that is useful for policymakers and decision makers, ultimately we know that this intervention will save lives. And it's important just to pursue newborn screening with that in mind and really put the economic costs after that as a second priority. So I think that will be it for today. I want to thank you all, and I'm happy to answer any questions that may come up.
So now we will be moving on to our panel discussion. So if you haven't already, please post your questions in the chat, general or specific. I would now like to welcome Marika Meyerdorfer-Mayer, co-founder of CAH Austria and CAH International, a nurse with lived experience of CAH.
Yes, thank you so much that I can speak on behalf of CAH International tonight to you. CAH International is a network of patients and parent groups all over the world. At the moment, we have around 25 countries, contact with 25 countries all over this world. And we just got started 1 year ago with our work, with our CAH International work. So we were a quite young organization. Yes, I have CAH myself. My profession is a nurse. And I'm doing lots of CAH voluntary work in Austria and also on international basis. I assume you all know what CAH is. It's a genetic condition. Our adrenal glands cannot produce cortisol, which is a vital hormone. And if CAH is untreated in the severe forms of CAH, it can cause adrenal crisis, and children die in this adrenal crisis. That's why CAH is in a part of the newborn screening in many countries. In Austria, in my country, in Europe, we have newborn screening since for more than 40 years already, 40. So we have it for a very long time. I would say in the 20th century, in the last century, there were two relevant developments for us as people with CAH. One relevant development was the discovery and then the synthesizing of cortisol, which made treatment possible. Before, there was no possibility for treatment for people with CAH. Children died in the adrenal crisis. And on the same level, on the same stage, I would say, is the implementation of newborn screening. It was the second relevant development because it makes early treatment possible. And early treatment is, as we heard before, so important because then children do not come into the adrenal crisis and their lives can be saved. Next slide, please. Next slide. Okay. Yeah, I want to introduce you two children from Austria who benefited from the treatment which is available in Austria and from the newborn screening. I want to introduce you Peter. Peter was born about 10 years ago, and 8 days after his birth, his parents were called by the hospital again to come back with their son, and the doctors explained to them, we found something at the newborn screening. Your son has a genetic caused condition, which we call CAH. CAH can be treated well, so don't worry, CAH can be treated well. And then the doctor, we have a very, very special doctor in my area, he tells this sentence, every family, your son or your child will become just as smart and beautiful as all the other children, so don't worry. And this is the reality for children who have access to treatment and early access to diagnosis and to treatment. And now 10 years after his birth, Peter loves to play football, soccer, whatever you call it. He grows well, he learns well, he enjoys life like every 10-year-old boy. The only difference to other boys is that he has to take his cortisol 3 times a day. So Peter, he survived and he lives a good life as a boy here in Austria. And I also want to tell you about Caroline, a girl here in Austria. And as we heard before, for girls, CAH has several specialties included. One is that a side effect of CAH, I would call it, is the excess of androgens, which cause a different appearance of the external genitals. So then the parents of Caroline, they thought in the beginning they have a boy, they have a son. until 10 days after birth. They thought, oh, we have a son. And then they were called by the hospital. The doctor said, please come again to the hospital. We have to talk to you. And the doctors told them, your child has a genetic condition called CAH, and they explained parts of CAH to them. And then they told them, your child is genetically and in all the anatomic parts a girl. So you can imagine this was big confusion for the parents, really big confusion for the parents, but being surrounded by a sensitive and very caring medical team, Caroline's parents were able to cope. So Caroline is now a smart, active young woman, also taking her cortisol every day. And she says, I am glad I grew up as what I am, a girl. Next slide, please. So the relevance of newborn screening for us as people with CAH, for children, the early diagnosis helps them to survive. So we heard about this, and this is so important. For parents, early diagnosis before having the salt wasting crisis, the adrenal crisis, the early diagnosis prevents it. It helps them so much to cope. And for us as girls and women with CAH, the early diagnosis helps us to find our identity as women. So it's a big, big thing for us to have newborn screening. For the discovery of cortisol, 3 scientists received the Nobel Prize in 1915. Mr. Kendall, Mr. Reichstein, and Mr. Hensch. They are our 3 heroes because of their findings, we as people with CAH can survive. And I would say for the implementation of a newborn screening, each country should get something like the Nobel Prize, because each country who has newborn screening helps us to survive, helps parents to cope, and helps girls to live as what they are, girls. Thank you so much.
Okay.
Thank you so much, Marika, for your great insights. I would now like to introduce Professor Diane Webster, Vice President for the International Board of Neonatal Screening, and a variety of other roles pertaining to newborn screening.
Thank you very much, and thank you for the opportunity to participate. I've really enjoyed listening to the presentation so far. There is so much to discuss in this area. Could we have a look at the next slide, please? This is a slide put together by Professor Jim Bonham, who is the president of the International Society for Neonatal Screening, and it tells you fairly graphically what screening is like throughout the world. And the really telling thing is the line at the bottom. Only about 30% of babies in the world are currently benefiting from newborn screening. In a little bit more detail on the next slide, just had a little bit more detail about where some of the different regions are at. The International Federation of Clinical Chemistry and the International Society for Neonatal Screening about 2 years ago formed a joint task force to see how we could support countries who were looking at introducing screening. We made a questionnaire and it had responses from about 400 individuals from about 85 different countries, and from that we have picked out some where we think screening is likely to be relatively easy to get started, and we have a plan to have in-country meetings in some of those places. So last week Professor Bonham and I were in Cape Town looking at a pilot project in South Africa. The key things that we have found difficult for some countries thinking about implementation is first of all, is understanding that we get tall, smart children with hypothyroidism only if we have many, many different players working together. And although the International Federation of Clinical Chemistry thinks that screening is largely a laboratory activity, it really, really isn't. To get good outcomes, we need maternity services, we need families, we need follow-up services, we need paediatric endocrinology, we need available medicines, monitoring laboratories, diagnostic laboratories, scanning facilities, and most importantly, government and sustainable funding. And there are in fact very few people, there are a lot of people internationally who would really like newborn screening in their countries, but very few who have been able to pull together an implementation group that's got all the key parts in it. But we really look forward to supporting wherever we can. Particularly, there's a lot to discuss in the way, and particularly Emma's presentation around cost utility, all sorts of work to do. And I and the International Society is very happy to help and support where we can. Thank you.
Thank you, Diane. So for right now, I'd like to introduce Dina Matos, Executive Founder of CARES Foundation and founding member of CAH International, and she is going to come to the front. Thank you for joining us.
Thank you. Hello, everyone. It's my pleasure to be with you today. As Executive Director of CARES Foundation, the only U.S. organization that is solely dedicated to supporting patients with CAH, CARES embarked on a grassroots campaign in early 2000 to advocate for newborn screening for CAH in the U.S. And fortunately, due to that work, since 2008, every state in the U.S. now tests babies for CAH at birth. So most of you know this, but newborn screening is the most common ways that babies affected by classical CAH are identified. Most babies found to have CAH during newborn screening age. Now, the most severe form is salt wasting, and it's a serious condition needing immediate treatment, thus the importance of newborn screening. The expansion of newborn screening outside of the U.S. is a different story. Patients with rare diseases like CAH face a diagnostic odyssey to find the correct diagnosis, which may last many years and create a burden for caregivers, healthcare systems, and society. These diagnostic delays have repercussions on the health and economic burden created by rare diseases. Increasing the adoption of newborn screening and promoting early steps to improving health outcomes for patients. A coordinated multi-stakeholder effort from leaders of patient organizations, government, industry, medical societies, academia, and healthcare services is required to increase the adoption of newborn screening programs. CAH newborn screening implementation is not yet a worldwide consensus, which we've heard tonight. In part, it reflects the inconclusive data regarding the cost-effectiveness of early CAH diagnosis through newborn screening. Long-term experience with CAH newborn screening has been described. However, only a few studies have compared the screened and unscreened populations, and I'll talk a little bit about that in a minute. A recent UK survey revealed that newborn blood spot screening for CAH is not recommended because, one, aspects of the condition remain unclear. For example, at what point would children with CAH develop symptoms in their first month of life? Current evidence suggests that some children would present with symptoms before the results of their screening tests would be available in the UK and therefore may not be beneficial. Current tests are not accurate enough and may miss babies, resulting in false negatives, or tell parents that their baby has CAH, false positive, although some tests used in combination with the initial test show that promise for reducing the number of false positives. Further studies could help to improve the evidence relating to how good these tests are. Now, let me talk a little bit about the Brazilian cohort. And CARES was involved. We were asked that due to our success in the U.S. to write a letter to Parliament and give some guidance on based on what we did in the U.S. So Brazil's formal newborn screening program was created in 2001. Before that, testing for PKU was done through isolated initiatives, and screening for CAH began in 2011. Now, some of the outcomes for unscreened and screened salt-wasting CAH patients, this is based on a cohort from Sao Paulo. So here are some of the variables. The age at diagnosis. So age at diagnosis for unscreened patients was 39 days and screened 17 days. Percentage of hospitalization of salt-wasting patients, 76% for unscreened babies and 58% for screened babies. Percentage in the ICU, 36% unscreened and 30% screened.
It's like all difference.
And time in the ICU, 23 days for unscreened babies versus 9 days for screened babies. Now, there are significant regional differences in different parts of Brazil, and that is true in other countries as well. So, for instance, and this is one of the big issues still facing the newborn screening program in Brazil, is the age at the first medical appointment. So, in the Amazon region, for instance, it's 60 days before a patient is seen by a medical professional or an endocrinologist. This is a baby that has been diagnosed with CAH. In Paraná, it's 11 days. Sao Paulo, 20. So there are there's a range of variation between regions, and the social economic factors are also part of this. Now, in Brazil, as I said, this continues to be a problem. So the median newborn age at first medical appointment in 2016 was 37 days, 2017, 34, 2018, 29, 2019, 29, and in 2020, 30 days before a baby was seen by a specialist. We're moving in the wrong direction, so clearly more work needs to be done. Some other issues or which demonstrate the importance of newborn screening is about sex assignment. So sex assignment at birth for unscreened simple virilizing patients, this is in Sao Paulo, out of 90 simple virilizing patients, 67 were 46XX and 23 46XY. 25% of them were assigned as male. 15% grew up as male. 51% recognition of atypical genitalia. And the diagnosis was performed before 6 months of age on 20 patients. So clearly, again, work needs to continue to be done. Now, to talk about the economic impact of late CAH diagnosis. And this is again from Brazil. So inferred mortality rate of 10 to 26%. Cost for lost productive years was $2,239,744 to $10,276,591. For salt wasters, cost related to hospitalization and intellectual disability was $86,230 US dollars per patient. Simple virilizers, cost related to the treatment of precocious pseudopuberty with growth hormones was the cost of $4,232 US dollars per patient. Now, all of these costs could have been avoided by screening early. Here are some challenges to expanding newborn screening in Brazil and other countries as well. So the challenges are standardizing methodologies, creating diagnostic and clinical protocols, incorporating new therapies in the public health system, improve the national coverage as well as sample collection time, reducing the shipping time of samples to laboratories, inserting specialized multidisciplinary teams in all states and to provide a national, a newborn screening national database. So clearly, newborn screening has been a great tool for Brazil, but there are issues that continue, namely the factors of the issue with age of diagnosis and factors such as socioeconomic status and geography, which play a role in the discrepancies in CAH screening. Now, attention to these facts and outcomes underscore the urgent need to modernize the newborn screening system. While there's much work to be done, newborn screening has saved thousands of lives of CAH patients and millions of lives of other patients across the globe. We need to do a better job in newborn screening. And then the next step, whole genome sequencing, but we're far, far away from doing that. So together as a community, we need to work harder on behalf of patients to ensure that all patients are screened at birth. Thank you.
Thank you. I'm afraid to say as we have our Q&A.
Thank you, Dina, for your excellent presentation. We would now like to open the floor to questions. We invite those tuning in from Zoom to post your questions in the chat box or via Menti. In the meantime, we'll take your questions from those in person. If you have a question, please kindly raise your hand and we will call you to let us know your question and who it is directed to. So the first question we have is, what needs to happen to optimally scale newborn screenings between now and the year 2030?
I think the first thing that's needed is local people who really want screening in their community. And the next thing is for them to work with us and other experienced people. For example, as for Indonesia, a lot of advice comes out of the Philippines and the wonderful experience of Professor Carmen Padilla in establishing in the Philippines. But working to get a multidisciplinary group that's got representatives of all the people that are needed to get good screening outcomes, and then looking at what their government requires in order to do funding. So it might be a demonstration project, it might be something more on the lines of a pilot, it might be establishing diagnostic services or treatment services. It's of note, for example, that our survey showed there were a number of people in countries where they were screening but said treatment, for example, for hypothyroidism, and said treatment was not available. And I just think that we won't be helping people start screening or supporting screening unless that whole screening pathway from the offer to the diagnosis and the management and evaluation of outcome, unless that whole pathway is able to be implemented, we'd not be able to support. But keen and passionate and local is what's required first.
Thank you so much for that response. Our next question, which again can be answered by any of the speakers or panelists, we'll just open it up, is what has your personal experience with additional barriers faced by young girls with NCDs in contrast to the male population? Anybody is fine.
Just say that girls tend to face a lot of the brunt of specific disorders such as like congenital adrenal hyperplasia, just because of all the physical changes and characteristics that are involved. So there's a lot more cultural stigma in that sense, and just like speaking from a CAH perspective, boys generally, so with CAH there's a lot of like testosterone involved, so an excess amount of testosterone, and so obviously that leads to more male characteristics with girls, and so that doesn't really impact boys as much, but obviously impacts girls. So I would say it's just looking at the nature of the disorder, and then also like within specific cultures, there are a lot of conservative cultures where specifically with the lack of education within conservative cultures that don't really know much about CAH and what it is, there can be a lot of wrong impressions about it and a lot of judgment, and I think that's where the stigma comes from.
Well, if I may, so a few years ago, we were contacted by a young girl in Pakistan who was 24. She had cell wasting CAH and had atypical genitalia. And she reached out because she was desperate to get surgery to, make her genitalia appear more female. I shouldn't say normal because there's no such thing as normal. But she had been shunned by her family, had attempted suicide several times, and was reaching out because she was desperate. She was 24 and she wanted to have the surgery. So we connected her with a surgeon in the UK. She had the surgery and she reached out to us about 8 months later and said, "Thank you, you saved my life." Because I did not want to continue living with CAH. And that story is repeated many times, thankfully not here in the US, but in other countries as well. Stories we never hear about because, there is that stigma about the, what CAH is, and the first time someone who has no idea what CAH is Googles and you see what, comes up, some terms that we no longer use.
So for a German boy once said, CAH is the unworst disease you could ever have. So when I did my presentation and told you about Peter, for boys, if they get treatment, it's really, I would say, an easy treatment, and life is not too difficult. If you compare it, for example, with children who have type 1 diabetes, it's much more disease management to do than for CAH. And for girls, it's really can be quite difficult, and there are lots of barriers with the genitalia. But as I said before, for a lot of women of us, with women of CAH, it's sometimes it's also a kind of side effect. It's not the main thing with CAH for every woman, so it's differing very, very much. And I have big doubts about the negative psychological impacts of the excess of androgens. So I'm not too sure if there are really so many negative psychological impacts of the excess of androgens. I think it's lots of the reaction of the surrounding. If in the family is shame and silence about CAH, so it's vital to have good support for women, for families with girls with CAH, good support, psychological support, and also I think we cannot underestimate the meaning of patients groups, which really help families to get out of this shame and silence culture and to talk with their girls about everything enough. And then lots of barriers can be overcome.
Mm-hmm. Thank you so much for all your wonderful responses. Our next question is, what are the different social determinants of health that can impact birth screenings in your country? And a follow-up question can be, how can you work to reduce barriers to birth screenings due to these social determinants?
I want to refer to what Marika was saying. There's a lot of secrecy and shame around CAH. So often, and I'm not sure that this is answering the question, but often parents and patients don't discuss it outside their own family. And that can result in serious issues from, patients not getting the proper medical attention. We see often in young adults, for instance, when they leave their childhood home and go out to live on their own or go out to, the university, they don't talk to anyone about their condition. And unfortunately, in the last 5 or 6 years, I've learned of about 5 patients who died because they did not seek care. No one was alerted to the fact that they could potentially go into adrenal crisis. So, part of our education, and we're creating a new patient guide, is to talk about the importance of letting those around you know what the condition is that you have and what to do in the event of an emergency. But, for girls, this is especially difficult because of the secrecy and shame, because if you tell someone, I have CAH, their roommates or their classmates are going to Google it or explain what it is that they have. We have parents of young children who go to school and they say, well, what do we tell the teachers and the other students when my child has to go to the nurse, in the middle of the day to get their medication? They don't know how to deal with that. And even parents of boys that, don't have the issues with, the atypical genitalia, for instance, but because, they're under the umbrella of CAH, they all have CAH and it affects males and females equally. They don't want to discuss it, and it's a big secret, and that's a narrative that we have to change. There's no shame in having CAH. There's nothing wrong with. So we often say to parents, tell them that your child has a medical condition that requires medicine, just like another child with diabetes, for instance. But we have to change the narrative, and we have to, as difficult as it is. We have to educate, patients and families about the importance of, being open. And I know that's not an easy conversation to have.
Absolutely. Thank you so much to our panelists and for the discussion. Unfortunately, we weren't able to answer all of the questions. We do appreciate very much you all participating and asking these questions. And we hope to continue the conversation and allow those questions to be answered and the discussions to be had. So we'll hand over to Grace for closing remarks.
Thank you to our speakers and panelists for joining us today. And I'd like to start with reflecting on the Indonesian perspective. Thank you to the Minister for his video and Imam. It's wonderful to see the involvement of NGOs and government working together, particularly looking at the global need for newborn screening in relation to SDG 3, that is something that needs to be achieved on a global scale, and that has such a high prevalence in countries with such dense populations. 5 million infants per year requires a lot of newborn screening, and scaling that technology to successfully achieve health outcomes and reflecting on these multi-sectoral issues on that large scale is very important. And Fatima, thank you for reflecting on the gender issues that are faced within newborn screening. Drawing on those discussions in relation to stigma within our Q&A was very insightful. When we perpetuate this shame and secrecy, inevitably we're perpetuating the issues that we face with newborn screening. And that's really important for us to continue this dialogue and the discussion such as we're having here today. And looking at those psychosocial impacts and the long-term implications not only on health but on social health and well-being is vital. As with Emma, discussing those economic long-term hardship that is faced by families and patients, it's vital to consider all aspects. And as you stated, Emma, there's no way that you can place value on a human life, no matter how well these economic benefits and analyses are showing, which is also very important for government policy. Human life is that ultimate value. And then reflecting on our panelists today, Marika, thank you for reflecting on CAH International and the work that you've done within 1 year. The importance of quality medical care and that community support network really came through, and the difficulty of implementation, even reflecting on the Nobel Peace Prize for cortisol. There is such that global valuation of newborn screening and such a wide interest in ensuring that newborn screening is scaled and CAH is managed effectively. Diane, thank you for reflecting on the global dispersion of resources and outcomes and how those are intricately linked, and reinforcing this community-centred approach that's needed. There's a role for international communities that we are now aware of. Dina, thank you for sharing with us your fight for newborn screening since the early 2000s. It really is that grassroots necessary first step to quality healthcare, and we truly believe that investment is what is required. And what came through from all of our speakers is that there needs to be a global unity and harmony. So in reflecting on this year's primary theme, education, technology, and gender equality, we see how Clan and Mates for Kids work integrates the role of newborn screening. Mates for Kids is identified, as Kate has stated, the goal to reduce preventable mortality due to CAH by 30% by 2030, and there are 3 ways to do so. Improving access to medication, which is the first vital step to then scale newborn screening, and then support community development activities to promote sustainable community healthcare in the long term. Clan's strategic framework also rests upon the diagnosis of children with NCDs, and it's optimised through this early diagnosis. Once a child is diagnosed with a condition, this is when Clan's framework and community development activities can truly come into play. But Clan acknowledges that newborn screening is the first step, and it is the grassroots to achieving what we want to achieve. Newborn screening already exists. It's effective for preventing childhood morbidity and mortality, and it's necessary for improving the lives of children and girls living with NCDs, but it's not equitably available, and it needs to be. Clan and Mates for Kids and every one of our panellists wants to ensure that universal health coverage includes newborn screening, that is part of the development agenda. We want to ensure that it's part of the call for universal health coverage. It's unacceptable that children in low and middle income countries experience an inequitable burden of disability and mortality due to the lack of investment and scaling of this newborn screening technology. We can see the role of newborn screening in utilising innovation and technical change to achieve gender equality and long-term healthcare outcomes. What is required is investment, community development, research and government policy. So what will you do to advance this cause? Will you promote dialogue in relation to newborn screening and accessibility? Will you discuss implementation measures to improve access to medication and newborn screening? Will you get involved in or support the work of organisations doing so? Will you express your concerns to policymakers to ensure that newborn screening is part of the universal healthcare agenda? In some way, you can ensure that there is equitable access to newborn screening and be involved in this global discourse. For every child and for every girl, newborn screening is necessary. So what's your role? We invite you to reflect.
Our event has now concluded. Thank you to everyone who has been involved for your support in the success of our first hybrid CSW event. Specifically, thank you to Clan's partners, Lehigh University, for the opportunity to engage in this CSW 67 event, and to UN Women for providing the necessary platform for dialogue about the role of technology, education and innovation in advancing gender equality. Clan is unwaveringly grateful for the support of our community in allowing us to do the work we do, and hope that your support will continue into the future so that we can continue our impactful work. To stay up to date with Clan's work, please subscribe to our newsletter or follow us on social media, where you can find us on most platforms. Our contact information is available on the slides currently. Please don't hesitate to get in touch to learn more about the work that Clan and Mates for Kids does. We look forward to what we can achieve when we work together to make newborn screening accessible and to leave no child behind. Thank you once again.